to today's seminar. Uh, do note that it is being recorded. If you would, please, for those of you at home, mute your microphone while we are watching the presentation. And if you have a question that calls for a brief clarification, just go ahead and put it in the chat. I can relay it to the speaker so we don't interrupt the flow too much. But when we come to the Q&A segment, if you would prefer, you can unmute and ask the question yourself. I will also offer the same possibility to the students we have here at UNC. Alternatively, if you would like, you can post your question or comment to the chat. I will perhaps contextualize it and relay it to our speaker. So let me turn it over to Dr. Ed Hammond to introduce our speaker, and let us begin.
Thank you very much, David. I'm delighted to be able to introduce our speaker for today. His name is Benjamin Goldstein, Ben Goldstein as we know him. He's a professor of biostatistics and bioinformatics at Duke University and is the chief for the Division of Translational Biomedical Informatics, which makes him my boss. He serves as the Director of Data Science for Duke AI Health and the Associate Chief Data Scientist for Duke University Health System. Dr. Goldstein's research focuses on meaningful use of electronic health record data for both inferential and predictive modeling. His work sits at the intersection of biostatistics, biomedical informatics, machine language, epidemiology, and implementation science. He has studied how the data we observed affect EHR-based studies, how to develop clinically useful decision support tools, and how to make EHR data accessible to investigators. He has received funding from NIH, FDA, CDC, and PCORI. He works closely with the Duke University Health System, developing, implementing, and evaluating risk prediction and clinical decision support tools, and providing guidance on analytics for quality systems. Dr. Goldstein received his PhD in biostatistics and MPH in biostatistics and epidemiology from UC Berkeley. He has secondary appointments in the departments of population health sciences and pediatrics and is a member of the Duke Clinical Research Institute. He also is a member of the American College of Medical Informatics. Ben.
Thank you. And I may be Ed's boss, but he will always be my teacher. So thank you very much for that introduction. I'm going to presume everyone can hear me well. And also feel free to put questions in the chat as I go along. I'll try to keep it open and amend and address them as they come about. So thank you very much for having me here today. This is actually a talk that I really enjoy giving. It's if you've given lots of talks, there are some talks that kind of have different degrees of meaningfulness to you. And what I really love about this talk is none of it is work that I've done, actually. So in fact, everything I'm going to be talking about has been work that's been conducted by fellows, PhDs, and master's students and staff. And I'm going to try to give kind of an overview of a lot of the work that our lab has been doing over the past few years, but it's really that work done by a lot of other people. I also want to acknowledge that methodologically, a lot of this work has been in collaboration with Matt Engelhardt, who's assistant professor within our department. And then there have also been a number of wonderful clinical collaborators, Jerry Dawson, who's the former head of the Autism Center, Lauren Franz, who's been serving as the interim head of the Autism Center, Gary Maslow, Marika Kaufman, Denai Fan, and Naomi Davis. So this work is really reflective of all of the wonderful and exciting things that they've been doing, and I've just been able to be a part of. So we're going to talk today about autism spectrum disorder. This has obviously become even more so a hotter topic, but it's always been a topic of interest within the medical and informatics community. As I assume most of us are aware, autism it's a developmental condition that has a very complex clinical presentation. It is characterized by a whole host of characteristics, both social and clinically oriented. It has also it also has a number of potential etiologies ranging from biological and genetic to perhaps environmental. And and so there's a lot going on when we in trying to understand autism. One thing that we know about autism in particular is that boys are four times more likely to be diagnosed with autism than girls. So as something to study and try to understand, there's a lot of complexity essentially behind it. One of the things that we have been able to study with regard to autism, and we've recognized, is that there are a number of co-occurring conditions that are common within autism. This includes both various psychiatric conditions like anxiety, depression, OCD. It also includes developmental conditions like intellectual disability, language disorders, motor disorders, and then also general medical conditions like epilepsy, GI problems, immune dysregulation. So even though autism is really in many ways thought of as a social condition and it's diagnosed as such, there is a medical heterogeneity behind it. Early work from our group, this is actually work that predates me, was able to show that children diagnosed with autism, as well as ADHD, have distinct patterns of healthcare utilization prior to age one. They have different rates of ophthalmological care, physical therapy, neurology, GI care, and endocrinology care. This kind of serves as a basis for being able to say that maybe we can use medical data to try to understand which kids are likely to become to be diagnosed as autistic. There is within primary care for children current autism screening. This typically occurs at the 18 and 24-month well child visits. The standard tool is what's referred to as the MChat, which is a developmental screening tool that's done by the pediatrician and with the parent. It has okay performance. It doesn't have really the best sensitivity or specificity. It's known to not perform as well in girls as well as children of color, and parents with lower education and SES. And most importantly, it's known that pediatricians don't always know how to react to it. That when the score is generated, they don't always make a referral. So while there is autism screening occurring within primary care, it's not quite clear if it's optimal and if it's being utilized properly. That being said, we also know that there's an opportunity to predict which kids are likely to be autistic. Again, this is earlier work from colleagues, where being able to show that at early ages, we can be using medical data, we can actually begin to predict which children are going to be diagnosed as autistic, that we do have these differentiations based on the types of clinical conditions that are expressing themselves in early childhood. So the work that I'm presenting is really part of a much larger group of individuals within the Duke Autism Center of Excellence. And we have a number of grants and projects that are going on there that I'm going to talk about some within my kind of small slice of it. But we actually have there's a larger vision within the center. A lot of it is focused on how do we do early detection of autism. And we can think about a multimodal approach to doing autism screening, where we can use early childhood medical conditions to try to identify which children may be showing early indicators of autism. We can combine that with standard screening tools like the MChat. There's work going on around computer vision, where we can actually use folks in the group have developed an iPad app that can make an assessment of whether a kid is likely to be autistic based off computer vision, and that we can bring all these together to try to accelerate the time to diagnosis and ultimately treatment for autistic children. So what I'm going to talk about today is kind of our little slice of that larger vision of how do we do multimodal autism screening. And the goal here will be to developing a health system-based screening tool for autism. The substantive goal really that we have is that we want to develop a tool that can leverage routinely collected clinical data that identifies children likely to be diagnosed with autism. This would serve as a screening tool across well child visits to initiate further assessment. The key here is that we're not trying to make a final diagnostic. And I'm not going to show much data to this effect, but kind of one of the take homes from a lot of the work that we've been doing is that while we can get to good predictive performance, we're just given the rarity of something like autism, we're never going to get to the level of specificity where you can make a definitive yes or no assessment. But the goal is to really develop a tool that can help in essentially in a triaging process. While that's the clinical goal in mind, there's also an important analytic challenge that that we have to consider as well. Predicting who will be diagnosed with autism is not an easy task, particularly using off-the-shelf data. While most of the work out there, you have AUCs that maybe get up to 0.7, so kind of basically enough evidence to say that there is a signal there, but not necessarily a signal for a true clinical decision support. So a lot of the work that we're doing within our group is to really try to investigate a variety of different methodological approaches to try to improve a machine learning model. So what I'm going to be presenting here today is the work that this group of students and fellows and staff have been working through to try to really kind of interrogate this problem from various angles to try to see how can we improve a predictive-based model. Okay. It's important to understand what data we have. So the data that we're focusing on are primarily data from the Duke University Health System. We have focused on data from 2016 through 2024. That's mainly to keep things within an ICD-10 world. Our cohort, we tried to create a broadly defined cohort so we identified children who had a well child visit prior to 12 months of age. The reason for this is basically children who have established a routine care at our health system. And then from this, we identified autistic children, a definition requiring 2 diagnostic codes, and we used the timing of the first visit on the first diagnosis as our outcome date. Among this cohort, about a little over 1,000 children, about 2.5%, which is in line with epidemiologic findings, are diagnosed with autism. We've done most of our analyses within a time to event framework to account for just censoring, where we censored kids at their last health encounter. And overall, we split the data into training and test sets. So this just kind of gives you an understanding about when kids are diagnosed, at least within our data, with autism. This is a little bit earlier than what you might see in other population health data, primarily given the focus that we have within our clinics on screening. But for the most part, we see about a median age of diagnosis around 36 months or 3 years of age. Typically, by about 8-9 years old, you will not see many. Most kids have already been diagnosed if they will be diagnosed. Very few kids are diagnosed prior to 18 months, or at least have that first code that has a suggestion. So we're really trying to focus on that early childhood period to kind of help and improve that screening process. In terms of thinking about the data and the features that we brought in, that we're bringing into our analytic model, as mentioned, we have data on 48,000 patients or children. This includes over 9 million codes, across 16,000 unique codes. We have data that have been grouped into diagnosis codes, procedure codes, labs, medications prescribed, medications administered. Essentially, your standard EHR-based data, though we'll talk about a little bit later, is some of the other kind of EHR component elements that we are looking at incorporating in. Okay. So let's get into some of the actual methodological work that we're doing here. So the first problem that we really had to address and solve here is how we actually go about even working with the data. So this has been work that's been kind of sitting across the entire group. It's being led by Scott Sun, who's a PhD student, and he's also been supported by Selena Yu, a master's student. And this is really improving the representation of high dimensional data. So EHR data, particularly diagnosis codes, consists of very high dimensional data that are often sparsely observed. Traditionally, and if you've worked in the space, we've used clinically oriented grouping systems to organize those codes. That may be doing clinical phenotyping and maybe using things like CCS coding to create organ system codes. But for the most part, this may not really be the most efficient representation of the data. Where I'd say that the field has really kind of moved into, and our group has really, dove head first into is really taking what is now what you consider now like a language-based approach, and working towards notions of foundation models, so that we can treat these observed codes as a vocabulary of words, essentially like a language. We can learn and what I refer to as embeddings that more ideally represent these data in a lower dimensional space. So why do we want to think about using embeddings? So they provide a dimensionality reduction first and foremost. We can convert the 70,000 ICD codes, 72,000 CPT codes into essentially a sparser 256K vector, which is much easier to work with. The idea behind them, and which I'll go into a little more detail, is to learn where the relationship between codes, where similar codes will have similar embeddings that help to capture the underlying relationships and the pattern in the data in a nonlinear way. And then what we find, and I'll show some data for this, is that the model that ultimately when we use these data within our machine learning models, it generally leads to better performance when we work with these dense vectors rather than these sparse categorical data. So how do we think about converting data into code? So the most classical way of doing this is using what's called a word-to-vec algorithm, where we gathering the codes in a chronological sequence. We can add each ICD code, for example, but this is not just ICD codes. It could also be our CPT codes, our laboratories, our medications, as a word in a sentence. And then each patient's medical record for that encounter essentially becomes a sentence of information. We can think about a series of encounters operating as akin to a paragraph. So this is this idea of turning medical codes, medical documentation into a language or a vocabulary. The simplest algorithm behind this, and where we kind of started, though we've moved past this a little bit, is using a continuous bag of words algorithm, which tries to predict a word or a code based on its context or the words or codes that exist around it. So we can think, so this allows us so from here we can think about converting the codes into embeddings. We start by creating an initialization of those embeddings by creating our weight matrix. This gets passed forward to predict to compute the prediction for the target code. We allow for a loss. We go through, we iterate through this process, and this ultimately creates our vectored representation of these data in a much sparser, in a much more dense way. So if we think about each so this is kind of the resulting representation. Now, each column is essentially a representation of data, which is a nonlinear combination of all of the information that comes in behind it. So all of the other clinical data. And then each row is essentially a person that allows us to represent their representation. Okay. So this is kind of just some basic work where when we started doing this work, starting with CCS coded data, our initial off-the-shelf analyses were producing AUCs of around 0.66, again, that middling range. Just simply moving to this representation of data was essentially able to boost our performance by up to 0.75, a significant improvement, basically saying that by taking all of our data, organizing it in a different format, boost that overall performance. Okay. So that allowed us to really kind of say, okay, how are we going to organize our data, work with our data? But then we needed to start thinking about what we actually want to do with it. So this is, so in many ways, this is kind of the core of the work that we're trying to get towards, which is making predictions over time. This is work by Gabby Walczak, who's a master's student. And the goal here is to try to develop predictive models. The challenge where we have predictive models that need clinical information that gets added over time. And what we don't know is at what age point we'll be using our tool. So we want to be thinking about how do we get towards dynamic prediction? And importantly, how can we generate a model that can operate efficiently at multiple points in time? We don't want to just have a model that's operating at either 12 months of age or 18 months of age or 36 months of age, but we want something that can work across all ages and all kids that can efficiently be implemented into the EHR system. So the work that that she worked through is developing what essentially we call a stacked data setup, where where the data are stacked into 6-month bins, going from 0 to 6, 6 to 12, up to 5 years of age. For each child, we create a structure of sequence bins that pulls the EHR embeddings within each of those bins. And then we label if a diagnosis of autism occurred within that bin, yes or no. Each child contributes one record per time bin, and then creating the stacked person period data set. So we may have for a child, they have bins for 0 to 6, 6 to 12, etc. And then we have a sequence of data where we have the number the number of bins for that child up to that sensory event across those pool embeddings, and we have their outcome Y, which is their sequence of outcomes of whether they were diagnosed with ASD, yes or no, in that time period. This allows us to get towards a dynamic model where we can model when ASD occurs by estimating the discrete time hazard across each of these 6-month interval bins. So we can use this outcome. So as we use this outcome label, we can have at any particular point in time, is a child diagnosed with ASD, yes or no? Each child is represented through that sequence, and the output that we generate are a series of hazard logits, and we can generate predictive probabilities of the probability that you've been diagnosed with ASD up until a particular point in time, conditional that you survived up until that point in time. So this allows us to create what we're calling we're allowed to get our dynamic models over time, where we can look at in 6-month information. What is that performance of that model? And we see that the model performs a little bit worse earlier in time. I want to acknowledge that some of these data we know need to be updated a little bit, but the general pattern is the same here, where the model performs a little bit worse over time. And then as a child gets closer to about 18 to 24 months of age, and more information is essentially collected on the child, the model performance improves. And really by 36 months of age, we essentially have a leveling off of that model performance, meaning that we've probably seen enough clinical information and learning more information about a child is not going to improve as much of the prediction. I do see in a chat that we do have a couple questions about genetic data and hereditary information. We don't have any genetic data that we're using here. We do, and I'll show in a moment, we do have a little bit of information about mom. So we do know which the data we have about the mother who gave birth. We don't have any genetic information, but we do have some clinical information that we can think about incorporating into the models. Okay. So now we kind of have a basis for clinical performance, but we want to figure out ways that we can make this even better. So this was work by an AI Health Fellow postdoc, Angel Wong, where the idea was to think about how we can borrow information from related conditions. So the challenge here is that autism is a relatively rare event, if you recall. So in our data, it's about 2.5%. But we do know that children with other neurodevelopmental conditions may have similar co-occurring conditions as autistic children. So they may share some of the features that we're interested in. So the solution that we thought through, or Angel thought through, was to generate a model within a multi-label setting that borrows information from other related neurodevelopmental conditions, and then inserting a conditional step to make the rare event prediction more efficient. And this work has been published as well. So this is kind of just this overall support for this idea that there's overlap. So if we look at other developmental disorders, we see a lot of overlap with autistic children, things like ADHD, motor delay, developmental delay, and language delay across. So this kind of supports this idea that we can think about borrowing from these other conditions. Just another visual of this, again, showing that there's a lot of overlap across these groups. Okay. So the setup for the conditional model is that it involves breaking the task into 2 steps. First, we want to predict who will have an NDC, and then we want to go about differentiating the NDCs. So the first step should be a somewhat easier task that leverages shared features across the various NDCs. And the second step involves differentiating who will be diagnosed with autism. And we can make this task a little bit easier by removing kids with low or no probability of an NDC. So we're essentially asking two sets of questions. Do I think you're going to have any neurodevelopmental condition, conditional on me thinking that you should have some neurodevelopmental condition? What is the probability that I think that is going to be autism? So this is so in the setup, she tested out a few different model structures. The first was just kind of thinking about just doing a single one label neural network. The next was thinking about doing a multi-label neural network where we said, let me try to predict autism, ADHD, motor delay, et cetera, each separately. Then separately, we can think about doing a conditional one label model where we first predict what's your probability of having any NDC, and then conditional on that having autism, and then the combination of all this together into this what we call a conditional multi-label neural network. First, let me try to predict what if you're going to have any NDC, and then which NDC I think you're going to have. And so just kind of jumping right into the results here. So basically what we find is that this does, in general, improve predictive performance. If we just do a single one label neural network, we get an AUC of about 0.76. In the conditional multi-label model, this jumps up to about 0.8. When in our ablation study, when we looked at the individual steps, both the multi-label neural network and the conditional one label model, we see somewhat more moderate performance. So overall, this is suggestive that the combination of these two together improve the overall predictive performance. And we also looked at just to understand why this may be happening, to understand kind of the mechanism behind it. And not surprising, what we found was that there's a lot of correlation between the feature importances across these different neurodevelopmental conditions. On the left-hand side, we have the correlation between feature importances measured by SHAP values in just the basic neural network. And then what we see is that within this conditional multi-label model, it essentially forces the model to even boost those correlations even more. So essentially, it's pushing the model in a direction that really emphasizes the shared features across these different conditions. I will say this has actually been an approach that I've been long interested in for a while, because we can find there's a lot of opportunities to think about these conditional approaches for hard to solve problems across health. And one problem we worked on in thinking about use of antibiotics, which again, where we first developed a yes or no model for any antibiotic use, and then a conditional on having some antibiotic use. We then generate a count model for the number of days of therapy that an individual would have for antibiotics. In another study, in trying to understand hospital length of stay, similar setup, where we developed a conditional model of a yes or no, would you have a long length of stay, and then conditional on whether you'd have a shorter length of stay, a model for the actual length of stay for those individuals. So I've actually I find it really interesting that you can find these opportunities to really break down problems into multiple steps to make the modeling task ultimately a little bit easier. Okay. Moving forward, so this is further work by Scott Stein, also what we call borrowing from what he calls borrowing from the future. The challenge here is that it's important for autism assessments to be made as early as possible to improve referral to services. But however, the most useful predictors for autism are those observed later in development. As we saw from Gabby's work earlier, right? We're able to make our predictions get much, much better as we get older in age, but we ideally want to make those predictions much earlier in age. So the idea that Scott came up with here, which I thought was really creative, was to try to treat data over time as different modalities. And so there's a lot of work within multimodal learning, but instead of thinking about multimodality from the perspective of combining structured data and unstructured data, we can think about the actual time periods as different modalities, where the idea being that we can train a model across all modalities and then test the model using data from only earlier modalities. So this is kind of the idea here. We can consider 3 periods of time. For example, the prenatal period, the birth encounter, and the infant toddler visits. I apologize for the cartoonish ChatGPT generated figure. It's really the best I was able to come up with for that. We can think about parsing each period as a point in time where we'd want to make a prediction assessment. Data from the developmental period, for example, while child visits, we know has that strongest predictive performance. So the modeling goal is to train a model with all available data, run and test the model with only a subset of the data, and practically we're leveraging later data earlier. So the general setup that Scott put together is that, again, we have these series of tokens over time. They get sequenced into the embeddings vector. We learn the embeddings across all those tokens where places our data are shared in structure. The tokens are aggregated, or the embeddings are aggregated from each of the modality to create an overall modality embedding. We process the modality embeddings through an encoder using a contrastive loss, and then a fusion model that is able to aggregate overall patient representation across these embeddings. One of the keys here is the contrastive structure, where he creates contrastive pairs based on the modalities that an individual has. So we have positive pairs or individuals that are having the same modality, or in this case, the same period of time, where those negative pairs are for the modalities that a child doesn't have, and this is what allows for the improvement for those earlier modalities. So what we're able to show it is that as we add this contrastive learning steps, so here in step one, where we're looking at our prenatal period, we're able to boost our predictive performance from 0.68 to 0.73. When we use just the birth encounter data, we have a baseline performance of 0.7, which gets boosted up to 0.76. And then finally, our developmental data for these older kids, the predictive performance essentially stays the same. So while we never get our model up to the point what we would do at, say, 24, 36 months of age, we're able to improve our predictive performance at these earlier points in time, which will ideally help improve overall early screening and early detection. Okay. Moving on to some of the newer work that we've been engaging in. So this is work by Gafei Li, who is a master's student. And now what we're trying to do is move beyond just these structured, easy to use clinical EHR data, EHR data elements, and try to ask the question, can we add in more information here? So most EHR models incorporate standard clinical data elements, as mentioned, so things like diagnoses, procedures, labs, medications. But also, as mentioned, as a behaviorally informed condition, we need more than just the clinical picture to accurately assess autism. That we can do. We've already shown we can do decently well with just knowing about the early childhood medical conditions, but ideally we'd be able to do better if we knew more. So fortunately, so one of the reasons actually I've really enjoyed working in pediatrics is that kids go to the doctors regularly. We have a lot of routine information on them, and in particular, we have more nuanced qualitative data on them as well in the form of developmental screening tools, and this allows for an opportunity for more nuanced assessments. So one of the more typical tools is what's referred to as what's called the Survey of Well-Being of Young Children, or the SWIC. It's a developmental screening tool administered at each well child visit through 60 months of age. There's 12 in total. And it assesses across language, motor, and behavioral development. Just asks a series of questions. It's been used regularly at Duke since 2018. So what I'm showing here on the right is the 18-month SWIC. And you can see that it asks a variety of questions, and some that may be indicative of a developmental challenge. So asking questions around language. Is a child using words? Asking questions about motor development. Can a child climb up a ladder? Can they name different things? Are they able to ask for help? So while it's not a direct assessment of autism or any particular developmental concern, it is something that can be, the question that we're looking at is, can it actually be indicative? So this is actually very early work that we're putting together. I don't. Some of the clinical collaborators of mine who may be here probably have not actually seen this yet. But this is actually really exciting to us because this is looking at kids who are diagnosed with autism, and what Cafe looked at is their SWIC scores over time, and looking at do the kids who are ultimately diagnosed with autism, do their SWIC scores differ? And the short answer is yes. And even more so, we can actually see when they begin to differ. So what we're seeing over time is that our age, sex, and race matched controls have a relatively stable SWIC from 0 to 60 months of age. But our kids who will be diagnosed with autism in the future, while they start off at the same SWIC level as our controls, by 9 months of age, basically, by that 9 month well-child visit, we start actually seeing a statistically significant differentiation in developmental screening. And this actually really begins to max out around 24, 36 months of age. So this is actually a really exciting signal to both indicate that yes, the SWIC as a screening tool can differentiate kids who are autistic and who are not, but even more so, it helps with this overall goal of being able to say, can we improve early detection? And the answer is likely going to be yes as we begin to incorporate in these information. The next step in this work is to then be able to say, again, thinking back to some of these multimodal perspectives, is incorporating these data and from a multimodal way, incorporating it with our other clinical data assessments. Yes. So great question about how we treated undiagnosed autism cases. So the short answer is that we didn't, right? That this is ultimately going to be the challenge of in any kind of real world data, is that we're really dependent on the accuracy of the data. It's something that actually Matt and I have started talking about a little bit as trying to understand actually why some of the modeling work that you see earlier in the literature actually looks better than some of the modeling work that's being done today. I'll give credit to Matt on this potential hypothesis, right? So I don't think we haven't confirmed this, but I'll throw out a hypothesis is that if you use real world data even 5 years ago, the diagnosis rates of autism were probably a little bit lower, which means that the more easy to diagnose kids were the ones who were being labeled appropriately, and that there was probably an underdiagnosis of autism occurring. With more attention to autism, we're getting better screening, we're getting better diagnosis earlier, which actually potentially means that we're also getting the more borderline cases and essentially the more harder to diagnose cases. From a modeling perspective, what this actually means is we're potentially creating a harder prediction task. So it's actually, again, this is kind of a new hypothesis that, that at least Matt came up with, that I think is actually an interesting thing to think about is how our labels essentially change over time and what the impact of that could be on the quality of our models over time. Okay. Another question that another source of data that we want to bring in. So this is work by Zheng Xu, who is a PhD student now, is adding in data on clinical notes. Again, to kind of expanding our source of data, even more than behavioral documentation, there potentially exists information within the clinical narrative. Clinical notes at different well-child visits can capture age-specific signals. Ideally, we want to know, can we combine that information from multiple visits to improve predictions? So the solution we're thinking through, or say Zhang is thinking through, is using clinical notes at different well-child visits, and he's considering two different approaches. One is a static encoder, which uses 10 separate bioclinical BERT models, each fine-tuned to be an expert on the language of a specific developmental age. And then the second approach he's trying to work through is more of a temporal aggregation using a gated recurrent unit that consumes the sequence of the embeddings as a trajectory over time. So as we think about the longitudinal signal as clinical notes of each clinical, the key question becomes, can we combine information from multiple visits to ultimately improve prediction? So in that stage one work, we first had the visit specific representation learning. We have each model is fine tuned for each well child visit. So we have it for 5 days, the 5 day well child visit, the 1 month, 2 months, up to 24 months. Each model learns an age appropriate linguistic pattern. And then that output becomes an embedding vector that's specific to that particular well child visit. In the second step, and this is, and I'll show the results on the first step, but the second step that he's working through now is thinking about the longitudinal aggregation, where each patient, the embeddings are chronologically ordered. He'll handle the variables. There'll be variable number of visits, and we want to learn information that influences later outcomes. And this will incorporate time features such as the absolute age and the time gap between visits, ultimately generating a final prediction level using all available information up through a given history. So this is early information. Just using the baseline model performance. I'm sorry, using the well child visit specific performance. And again, we see a similar pattern that what we saw with the SWIC was that at earlier points in time, there's not a lot of information content within those well child visit notes, but once we start getting into 12 months and 15-month well child visits, we see a spike in information that things that are being documented by clinicians, again, prior to an actual autism diagnosis, are actually being indicative of a child potentially being autistic in the future, which means that even if a provider may not be aware of it, they're actually documenting information that could be useful for this task. Okay, I want to move into two other areas that we've been thinking about as we're doing this work. So again, the most important goal we're really after is how do we improve predictive performance? That's what we're working towards. But there's also a lot of interest in just generally understanding what are the potential biases in the models that we're using in the work that we're doing. So this is work by Peng Wu, who's a former master's student, thinking about algorithmic bias due to diagnostic timing. So the challenge here was that for most predictive models, and in our case is no exception, it's natural to use a time to event model. That's what we're doing here. It allows to account for censoring and loss to follow up. But what's really been kind of interesting for me to think, and a lot of the work I've done in the past is really trying to predict some clinical event that happens where time is really important. What's interesting about something like autism is that timing really doesn't matter. At the end of the day, it doesn't really matter if you're diagnosed at the age of 3 or diagnosed at the age of 8. If you're autistic, you're autistic. It may be that it took you longer to get found, and it matters to the child, obviously in the family. But as a predictive task, it is not. We're not trying to predict when a kid will be diagnosed. We just want to know who will be diagnosed. It's inherently different than trying to predict who is going to have a myocardial infarction or who is going to die, where you actually really do care about the timing of that event. So, but the problem then is, so if all we care about is who's going to be diagnosed, not the actual timing, the challenge that Peng started thinking through is that if there are differences as to when an autistic child receives a diagnosis, this can generate biases. And what we wanted to explore was what are the biases that are generated when you have differences of time of diagnosis. So the solution that she actually came up with and that she explored was to leverage what's referred to as a mixture cure model framework that can handle censoring, but place model emphasis on whether the diagnosis occurs. So this is real world data that where we looked at time to diagnosis. Across race or ethnicity. This is actually using North Carolina statewide claims data. And what we see is that there are meaningful differences based on when non-Hispanic white, non-Hispanic black, and Hispanic kids are diagnosed with autism. So, as mentioned, by about 8, 9 years old, all these Kaplan-Meier curves level off. Most kids will be diagnosed by that age, but we see that in particular across North Carolina, non-Hispanic white kids are diagnosed earlier than Hispanic and non-Hispanic black kids. So there's actually a legitimate reason to be concerned that there could be biases generated by timing of diagnosis. The general shortcoming of of these time to event models is that the time to event model assumes that for all individuals in the risk set, given enough follow-up time, all individuals will have the event. Um, this is not accurate, right? So again, time-driven models were developed with the mindset of time to mortality or time to an MI, where if we follow someone for long enough and no other event occurs, everyone will die. Everyone will have a heart attack. But not everyone is going to be diagnosed with autism, right? If you follow me for long enough, I will not spontaneously develop autism. So the general premise of time to event models is not necessarily correct. So this actually allows, so we can, so in these settings, and a lot of this was actually, this work has been developed within the context of actually cancer models, is that we can use a classification model to estimate the probability of the outcome, but this doesn't account for that censoring and differential follow-up. So we have trouble with a time to event model, and we have trouble potentially with a classification model. So this is the introduction of the mixture cure model, which was developed in the context actually of cancer studies, it's a parametric model that combines a survival component with a classification component. And what we're jointly modeling is in that pi z is what's the probability that you're going to have the event. And this actually has a conditional model framework to it, where then conditional on you having some probability of having the event, what do I think is the time interest? What's the time to when that event will occur? In most traditional representations of the mixture cure model, folks are most interested in the survival component of the timing when that event will occur. So if I'm modeling time to cancer remission, I recognize that not everyone's going to go into remission. So I want to model that probability, that conditional probability of having a remission, but then conditional on that when you will actually have the event. In our setting, we're actually most interested in that pi and what's the outcome probability. So the analytics setup is, again, we know that most autistic kids will be diagnosed by age 8. This kind of allows for us to play a little bit of a game where we know for kids born in 2014, we had data through 2022. We can say that we know the truth. We know if they will be diagnosed with autism or not. And we can compare predicted probabilities based on of when kids are censored, and using different types of models of logistic regression, Cox models, time to event models, and this mixture cure setup. So these so this is using real data, and the black lines are the actual event rates, and what we have, and then what we have on the bar plots are the predicted probabilities based on these different types of models. And in general, what we find is that so most models underestimate the probability of at earlier ages, but we find is that this mixture cure setup is able to do a better job of getting closer to those predicted probabilities earlier, the true probability. The reason, so we don't use the mixture cure model in our setup, but the reason that this is actually of interest to us is that there is actually a machine learning analog to the mixture cure model, which is the discrete time neural network. So in this setting, time is partitioned into bins where we fit a classification model for each one of the bins, and the model includes an extra output for the scenario where the event does not occur, allowing for the estimation of when an event is likely to occur and the probability of the event occurring at all. So what I really like this work that she did because it kind of laid out what the underlying problem is of just kind of naively using time to event or classification models. And then we can, and while the parametric solution is not as relevant to our approach, it gives a justification for this DTNN model framework. The last project I'm going to walk through is this was earlier work by Jiyoung, so he was also a master's student with me, and this was his master's project. Also thinking about bias, and this time thinking about detecting diagnostic bias. So we know that diagnostic codes are important for initializing services. Our phenotype definition is based off of diagnosis codes, but it's likely that there's a degree of under or late formal diagnosis of autism and other NDCs. So the solution that he worked through is to use provider notes to learn what an encounter of concern looks like, and then assess whether there are in fact demographic differences for when a diagnosis is made. So this was actually done. So we in kind of some related work focusing on late talking children, where the work here was to identify all children with a first late talking ICD code at a well child visit. He extracted clinical notes from that index encounter as well as previous well child visits. and using bioclinical birdie, learned what a late talking encounter looks like, and leverage the pairs in the batching of the notes, allowing to generate a classification model for late talking. So the long and short is that it's pretty easy to learn a model based on clinical notes, whether at a well child visit, whether there's concern about late talking. From a NLP standpoint, this is a very easy task. We have an AUC of 0.97. But what's interesting here is that it's not perfect, right? And that's actually what we're really taking advantage of. That particularly in this really high probability group, there are some kids who were misclassified with really, really high probability of being late talkers when in fact they weren't. And this is essentially this is the underdiagnosis. These are the kids who our label said you're not a late talker, but our model was completely convinced that this was a late talking kid. And this is what we're trying to uncover. So he went through this in a little more detail and really kind of looking at the question, well, how are these kids different? So in fact, so we do have so in comparing these high probability to low probability kids, the high probability kids were tended to be older. There were some systematic differences based on race, ethnicity. There were some differences based on on the primary language spoken. And actually, what's kind of been most interesting is that there were some systematic differences also based off of payer status as well. One of the things that we actually found was that there tends to be more underdiagnosis of kids on kids on private insurance as opposed to kids on public insurance. That's a disparity that we don't usually think about. And one of the hypotheses that we've come up with around that is that if you're on North Carolina Medicaid, services are actually covered for you, so you're more likely to get a diagnosis and get a referral. I do want to just touch on just some other work that's been kind of going on in the group because, like I said, there's a wonderful group of students and trainees in here, and I just really enjoy a lot of what they're doing. So work going on by Chin Wang, who's a PhD student working with Matt, is looking at optimal referral patterns, creating an optimal referral engine using reinforcement learning. So some data that I have not shown at all, but we're putting a lot of look into is what would be the impact of a CDS tool on the actual referral of kids, and in particular on the healthcare system, because we don't want to generate a model and a CDS tool that starts flooding the system with too many referrals that no one can handle. So this becomes actually this is actually can become a big problem, and it's very hard to come up with what is the right threshold to make a referral. So what Shane is working through is a reinforcement learning process to actually come up with an adaptive rule set that can say, given the amount of information I have about you, should I make a referral, yes or no? Other work going on by Zigwei Wang, who's a PhD student, is thinking about how we do multimodal learning, but make unimodal assessment. So some modalities such as notes are easier to work with retrospectively than prospectively. We may be able to pull those data from our data warehouse and create an analytic data set, but that doesn't mean that we can actually operationalize a model in real time that leverages notes or leverages the SWIC or things like that. So what he's working through is what he's calling a teacher-student model that learns from the harder modalities, the notes, but can be operated on with with those easier modalities, such as the structured data. Other work, so this is work by former master student Jonathan Way of how we combine information together. So we also have access to North Carolina claims data. While there are relatively few cases in the EHR data, while administrative data is much larger. So when he was here as a master student, he worked through an approach to create a model in the larger administrative data set and borrow that information to inform that local model. And then some other work is going on by another current PhD student, Feng Li, thinking about what is more along the lines of interpretable natural language processing. So extracting autism-related findings from notes is challenging due to their relative sparsity and the high volume of notes. So he's been working through a RAG-based retrieval augmented system that divides the clinical notes into short segments that can become learnable query vectors that are ultimately more interpretable. Just finally, and I guess I went to just about all the time, is that just to kind of highlight some of the other work in the larger collaboration. Again, we're not just focused on the methodological side, but a lot of really we care about this clinical question. So there's a human factor study understanding how we'd integrate a screening tool into the clinical environment, led by Lauren Franz. Naomi Davis is leading a lot of health services work, understanding questions on the diagnostic timing and referrals patterns for services. Marika Kaufman is leading epidemiological analyses to understand longitudinal development of co-occurring conditions. And then, as mentioned, we also have a lot of collaboration or development around late talking that's kind of sprung out of this autism work as well. So overall, the general conclusions are that I'd like to take home is that having an efficient representation of complex data can both improve tasks and make them easier. For hard prediction problems, one of the things that's come out of this for me is helpful to think about from where information can be borrowed. So can we borrow from other data sources? Can we borrow from various points in time? Can other modalities? Um, it's also important to be thinking about how bias can show up, and it can show up in a variety of ways. So we want to be able to explore it broadly. And really, breaking down a complex problem into smaller parts can lead to a lot of really interesting areas of investigation. But really, the primary take home is that I have been really fortunate to work with a great team of students, and that makes my life a lot easier and a lot more interesting. Because, like I said, I did none of this work. I couldn't do half this work because these methods were all developed after I finished all of my training. So having a great team of students is just wonderful to work with. And with that, I thank you for your time and happy to take any questions that would be helpful as well.
There have been, yeah, the chat has been very busy, as you've seen.
Yeah.
Um, and I'm not sure how to summarize it. Let me just ask a question of sort of where this goes next,
Yes.
because it suggests that you have an approach that may be able to help clinicians and presumably families understand the possibility of a child being somewhere on the autism spectrum. But how do you see that being translated into clinical practice?
Yeah, no, great question. So yeah, so ultimately where we want this to go, it isn't a clinic. That is the ultimate goal. And that in some ways that's the most important work being led by Lauren of understanding what that should look like in clinic. As I said at the outset, this will not be a a decision support. It will not, or not be a that says do this or do that. The
Mm.
outcome is too rare. The PPV will never get there in a meaningful way. We've started to kind of play with that question of what the impact would be on health services. So really, I see this as a triaging process, something it as a passive screening tool that can easily operate in the background. In some ways, it's less biased than a tool like the MChat, which needs to be proactively implemented and can be prone to individual bias. This just brings in your natural data and can ideal. And this is based off the work that Sheen is doing. Is given a certain threshold, raise an alert or raise an awareness. Where that goes next, that's where I really defer to my clinical collaborators, but that would go to kind of more of a secondary screening process so that we can more efficiently triage kids, not overwhelm the system of sending too many kids for referral, but really get the right kids in there so they can be screened and ultimately get into the right services.
So one of the questions in the chat sort of suggested that this is a spectrum.
Yeah.
There are nuances, and your approach sort of suggested it was a yes or no question, but in reality, of course, it's
Yeah.
a set of issues that may present in greater or lesser extent. So how do
Yeah.
you incorporate that?
No, so that's actually where some of our we're starting to talk about of where future work will go. So you're absolutely right. So right now we're just thinking about this as a binary yes or no, but it is a spectrum. And one of the things what we think about it is not just can we predict who's going to have autism, but can we actually predict the degree of complexity and the degree of and there's a lot that's a challenging thing to operationalize One of the ways that we thought about it is potentially around the amount of services a kid is going to need. There's challenges about that because you can get some weird feedback loops and biases, but that I think is really the important question is not just simply, and particularly as the diagnosis of autism has broadened, and this label is less specific to a more severe version. It's really meaning it's necessary to not just think about who is going to be autistic, but what does that degree of complexity ultimately look like? Again, to help prioritize who you want to get it into services first.
Well, we are out of time, but thank you very much. There have been a number of very complimentary post in the chat. One person suggesting that you should consider publishing in Learning Health Systems Journal
Mhm.
from Michigan University,
Yeah.
um, and that this was a fascinating talk. We thank you very much.
Yep. I apologize for going long. I'm happy to follow up with anybody who has questions.
Okay.
Thank you.
All right.
Thanks, David. Thanks, Ben.